imaging. We know that no longer one cancer, same cancer, say you take a breast cancer, colon or endometrial or ovary, same stage, same histopathology, not same, doesn't behave same in two different person. For example, moderately differentiated invasive ductal cell carcinoma T1, N0, M0, luminal AER positive, PR positive, HER2 negative. Don't think the cancer outcome treatment is same in two different patients on a given day. It is totally different. Now this is an era of organ preservation, multimodality, sequential treatment, personalized medicine at the genomic level. Because now initially we thought that a stage is more important. You all know that the previous HSCC in the breast cancer stage 1, stage 2, stage 3, stage 4. So we thought stage 1 is good, stage 2 is good, 3 locally advanced, 4 not good. But now we know that in the whole breast, the shift has happened based on the genomic profiling. Like once you do Oncotype DX or Can Assist or Mamoprate, any of them, patients may have a stage 3, but if it is luminal A, ER positive, PR positive, HER2 negative, Ki67 low, they behave like stage 2. So now there is a downstaging based on molecular or upstaging based on molecular. Initially we thought stage 1 cancer, a good surgery with sentinel lymph nodes done, maybe rarely you need adjuvant treatment. But now if it is the same early stage endometrial cancer or breast, if you do a genomic profiling and they are not favorable and they suggest they are aggressive, like T53 is high, or it is not luminal A. In fact, even though they may be stage 1, they may end up with taking adjuvant chemotherapy or radiotherapy. So no other cancer in last 2 to 3 years, so much change has happened the way it has happened in endometrial cancer. So today in short time, I'll try to analyze molecular classification of endometrial cancer and its implication in the management. Okay, so it's very, very important to understand. Initially, the traditional way we used to do is you do a surgery, do a frozen section, myometrial invasion, less than 50%, more than 50%, FIGO grade 1, 2, tumor size less than 2, more than 2. Oh, then you do a tailor-made lymphadenectomy with paraiotic. Then we moved to sentinel lymph node. Then we thought all nodes negative, less than 50% myometrial invasion, no chemo, no radiation, no brachy. But now it is not like that. So today I am going to analyze this. So although endometrial cancer is generally considered as a very good in prognosis, remember 75% of endometrial cancer, because they present as a postmenopausal bleeding. A lady doesn't wait when she has a postmenopausal bleeding. Menstruations have stopped for so many years, suddenly they have spotting, they come running to hospital. That is why 75% of endometrial cancer today come in first stage. However, cervical cancer don't present with bleeding, it just presents as a white discharge which a lady thinks as normal because they're used for premenstrual little white discharge, occasional now and then cervicitis, vaginitis, so they just ignore it. So cervical cancer, 75% come in advanced stage 3. When bleeding starts in cervical cancer, it's a big tumor, then they are already parameter invade, ureter fixed, so they are already stage 3B or sometimes 4A with bladder involvement. So endometrial cancer comes early. 20% of the women only die of the disease, 80% get cured. So the increased incidence of mortality over few decades needs to be analyzed. So traditionally, the risk factor for endometrial cancer was tumor type. Type means endometrioid, non-endometrioid. Endometrioid variety of adeno-CA, good. Non-endometrioid like clear cell, uterine papillary serous, or carcinosarcomas, MMMT, they were aggressive. Then FIGO grade. Grade 1, grade 2 good, grade 3 not good. Then grouping and recommendation management of algorithm, age, higher BMI. Most of the endometrial CA patients are type 2 diabetes, high BMI, more fat. They also have concomitant breast pathology or breast cancer. Then lymphovascular space invasion stage. So these were the risk factors prior. Lymph nodes, LVSI, stage, age, BMI, tumor type endometrioid, non-endometrioid and grade. So the molecular classification of endometrial cancer emerged from the study of TCGA. Please read about this, okay? So TCGA is the one which changed everything, the Cancer Genomic Atlas, which provided additional potentially superior prognostic information and classifier. And this does not replace clinicopathological risk factor. Remember, you should not replace clinicopathological risk factor. It has to be studied with you. And this endometrial molecular typing is applicable only up to stage 2, not for stage 3. Stage 3 you have to still treat like a traditional FIGO or TNM, which is also now aligned with FIGO, clinico-pathological risk factors. While tumor typing grading may supersede for classification, an underlying genomic abnormality, accurate assessment of other pathological parameters are very important and they're key in patient management. These include depth of myometrial invasion. We know that no myometrial invasion is superior to some myometrial invasion. Less than 50% is better than more than 50. Cervical vaginal serosal involvement is aggressive tumor. Adnexal involvement, about roughly 20% of the time in endometrial concomitant adnexa ovary tubes may be involved, and these independent stage like lymphovascular space invasion are also important. Now the current basis for treatment, how do you do? Currently the ESMO, ESGO, NCCN stratifies into low, intermediate, high risk. Okay, low, intermediate risk, high risk. They are based on clinical age, comorbidity, fertility, pathological FIGO staging, lymphovascular space invasion, grade tumor type. Morphologically, what type it is? Endometrioid variety is better than mucinous, serous carcinoma, clear cell, carcinoid, small cell neuroendocrine, large cell, mixed, undifferentiated, dedifferentiated carcinosarcomas. Current risk stratification was, if it is FIGO grade 1 and 2, endometrioid variety of cancer, muscle invasion not present or less than 50%, without lymphovascular space invasion, low grade. So it was thought that surgery cured, laparoscopic or robotic minimal access now as per the clinical trials is standard. So now that all endometrial cancers undergo minimal access, be it robotic or open, and especially they're obese and high BMI patients, so minimal access allows them to go home same day, next day, and least morbidity without compromising the outcome. And current 2 randomized control trials have shown that laparoscopic robot is not inferior, same, and better in minimal access. Intermediate is all are same, but only muscle invasion is more than 50%. FIGO 1B1. High intermediate is when LVSI is present or FIGO grade 3, even though it may be 1A. Okay. High risk is grade 3, 1B. All non-endometrioid histology are high, like clear cell. They behave like ovarian CA, clear cell, uterine papillary serous, and if it is more than stage 2. Okay, low, intermediate, and high risk. So factors which influence the treatment in endometrial cancer are preoperative imaging. The gold standard is MRI, but it is not compulsory if you have a frozen section evaluation, proper clinical examination. Tumor profiling, morphology, IHC, hormone receptor, MMR, molecular profiling. We know that traditionally, histomorphologically, we had type 1, type 2. Type 1 is metabolic syndrome, which is obesity, hyperlipidemia, hyperglycemia, increased estrogen, which is hallmark of a endometrial cancer. Type 2 happens in a very thin, frail, elderly lady. They have none of them. These patients are very thin. Type 1 have lower grade, type 2 has high grade. Hormone receptor, estrogen, progesterone are positive, usually if they are type 1. And type 2, usually they are hormone negative, HR, and then HER2 new positive, and they are very aggressive. Then histology, typically type 1 are endometrioid variety, type 2 are serous clear cell. Genomic stability, diploid feature, microstability, instability in 40%, aneuploid in type 2. TP53 mutation usually is not present in type 1, type 2 it is present. Prognosis, type 1 variety of endometrial cancer are good prognosis, usually 85% 5-year survival. Type 2 are very poor, overall survival is 55% at 5-year. So traditionally type 1 is a lady who is obese, hypertensive, diabetic, and then some breast pathology and high BMI, and they are usually less chance of node involvement, ERPR positive, well differentiated, less chance of spread, less chance of myometrial invasion, and they usually get away with surgery. Type 2 is a postmenopausal lady who is thin, frail, and then she has ER negative, node positivity chances very high, small uterus, atropic maybe, but still it may have a myometrial invasive disease, and then usually TP53 and prognosis is not good. This was the original Oakman subtypes. Okay, so now coming to the publication which happened in 2016 by the Annals of Oncology. Okay, this is a very important landmark paper of stratification. Please read this, which classify into low, intermediate, high, intermediate, and high. So what I will do is I'll just leave this slide, take a photo of this slide. So this was what was used by ESGO, ESMO, ASCO, and FIGO for treatment of adjuvant treatment and how to predict lymph node mats. Like if the size of the uterus tumor is more than 2 centimeter, myometrial invasion more than 50%, more than FIGO grade 1, grade 2, or cervical involvement, initially they required systematic pelvic para-aortic lymphadenectomy. Because it is proved that by Mayo Clinic study and also the study I published from India, that when pelvic node is involved, 69% of the time para-aortic node is involved. And when para-aortic node is involved, it is involved high para-aortic between the renal vein, renal hilum and the IMA, inferior mesenteric artery, not the lower nodes. Because right side, the ovarian pedicle opens into the vena cava 1 inch below the right renal vein. And the lymphatics always follow the veins, and where the small vein open into big vein, it stops stasis, backsplash is there, so the lymph node involvement is more. So right side, retrocaval, paracaval node just below the right renal vein because they follow the ovarian vein. On the left side, the ovarian vein opens into the left renal vein. So that is where the stasis happens. So the most common node is the left node, which is fork node between the left junction of the renal vein and the left lateral border of the aorta at the left renal hilum. So that is why these are the node importance. 4% of the time, pelvic node may be negative, but isolated para-aortic may be positive. If you don't analyze them by sentinel lymph node or lymphadenectomy, you may miss that positive node and think that it is node negative stage 1, and you think the survival is 97% without adjuvant, and they may recur because they are stage 3C, they would need chemotherapy, radiation in addition to the surgery. Okay, so this was the old treatment. Now everything post 5's trial has totally moved into sentinel lymph node. Now you do ICG, fluorescence based systematic lymphatic mapping and lymph node assessment both on the right side and the left side, and para-aortic is compulsory in endometrial because para-aortic node may be positive isolated in 4%, but sentinel lymph node. So then now it is proved that sentinel lymph node assessed evaluation of the node is superior to systematic pelvic para-aortic, where you give 40 nodes and pathologist cuts only one and sees 1 or 2 and then they say one section negative. But if you give sentinel node right, left and para-aortic, they do ultrasectioning at 2 microtome to rule out isolated tumor cell, and they have a higher chance of identifying node positive than a systematic lymphadenectomy. So now post 5's trial and all the trial, the ICG based fluorescence sentinel lymph node in pelvic, right pelvic, left pelvic and para-aortic is gold standard now, and then there is a standard of care. We are using that and not lymphadenectomy blindly, like in breast cancer now SLNB is totally the level 1 evidence. Okay, so now the problem for us is histological diagnosis shows higher inter-observer variation. In a pre-surgery DNC, if you think that it is grade 1, 40% of the time it is upstaged when you do a final surgery, and then you think that it is a FIGO grade 1 and I don't have to do node. Final histopathology comes as grade 3, then you have to go back with a sentinel node again. No patient likes to do surgery in 1 week. So histopathological traditionally predict local outcome, but prognostic separation of multiple types is unreliable and inaccurate. So preoperative DNC is only 46 to 70% accurate to the final biopsy. Final biopsy always upstages or downstages. So how do we plan this? So attributes of a meaningful diagnosis requires both understanding by clinician and the patient, objectives and clinically relevant, sensitive and specificity. So now this is the genomic cancer atlas of endometrial cancer, TCGA. Okay, so this changed the whole management of the endometrial CA. So I'm going to go and take you through by each flow chart and understand how to plan. Okay, now when you put a genomic profiling, remember there are 4 parameters: POLE, that is ultra mutated, MSI or MMR, then copy number low of endometrial cancer, copy number high of endometrial cancer. Based on these factors, T53, MSI, MMR, POLE, the molecular classification of endometrial cancer is divided into 4 parts. Is it really true? Yes. You do remember, except POLE, all can be done on IHC. What all can be done? MMR can be done on IHC. which is a counterpart of MSI. And TP53 is done on immunohistochemistry. HER2 is done on immunohistochemistry. Estrogen receptor is done on immunohistochemistry. Only thing not possible to do on immunohistochemistry is POLE, that needs NGS or PCR. NGS is superior. Okay, NGS from a biopsy blocks. Anyhow, nevertheless, if somebody has POLE wild type, not mutated, look at their survival, almost close to 100% without chemotherapy, radiotherapy. It doesn't matter what is there in that patient, muscle invasive, what is the stage 1A, 1B, 2A, doesn't matter. POLE, presence of POLE is very good. Ultra mutated POLE is almost 100% survival, no adjuvant treatment is required, no chemoradiation. Next, coming to MSI. Okay, so if MSI is hyper mutated, look at that, the survival is roughly about 80%. Then coming back, serous copy number high grade, one of the worst survival drops down to 40%, which would usually be TP53 mutation. Okay, so this characteristic was analyzed that the outcome of endometrial cancer separated into 4 curves based on these 4 parameters. So then also if you look back, I told you about type 1, type 2 endometrial cancer. Then they found that type 1 usually has P10 KRAS mutations, type 2 had TP53 mutations. So Cancer Genomic Atlas then separately looked up these two into and classified into molecular class 1, class 2, class 3, class 4. Class 1 is POLE mutated, class 2 is MMR, deficiency, and then class 3 is NSMP, means no mutations found, and class 4 is TP53 mutated. Class 1 best survival, class 4 worst survival. So again I am going to put this, please understand, in exam I want you to reproduce this. So based on this parameters, we classified it into POLE. It is present in 5 to 15% only. Okay, so remember this, POLE is present in 5 to 16% only. So it's very important to understand. Now MMR deficiency, that is MSI unstable, present in 25 to 30%, almost like 1/3. Then NSMP means PTP53 wild type and no other mutation found is in 1/3. Okay, so this is again in 1/3 for us. And then finally, if you look back, the TP53 mutation, so that is present in roughly about another 1/3. So now we'll take one by one. POLE mutated. This is called as ultra mutated tumor. Usually histologically they are endometrioid, high grade. Okay, tumor infiltrating lymphocytes. Prognosis excellent. Diagnostic test you can do either by a hotspot, Sanger test or NGS, but POLE is not identified on IHC, remember, it is a NGS. That is why it costs around 15,000 if you want to do. All other are IHC based 2 to 3,000. So in 5 to 10,000 you can do the entire genomic profiling of the endometrial CA. But POLE needs NGS, that is why it costs today about 15,000 rupees to do all this. And POLE mutated is low BMI, early stage, early onset. Now MSI or MMR deficient. They have hypermutated copy, high grade LVSI plus, intermediate, identified either by NGS or IHC, higher BMI. These patients would have Lynch syndrome. So in Lynch syndrome you could have colon, thyroid, breast cancer. They needs to assess. If on a biopsy block you have a Lynch, you have an MSI unstable or MMR deficient, then you have to do a germline blood testing. Then if it is positive, screen the family and do a genetic counseling. Then NSMP P53 present in about 30 to 40%. They usually are low grade, ERPR positive, intermediate. T53 needs to be checked, and then they have higher BMI. T53 are the worst. They have poorer outcome. They're usually high grade till negative. That's why bad till positive is good, and advanced stage and late onset. So remember this chart, very important. You need to reproduce this particular thing in exam. Now we will first look at POLE mutation. As I told you, POLE mutation is identified by NGS. They constitutes, unfortunately, it's a good strata, but only 10%. Remember, 10%. But if that is present, nothing matters. Node positive, node negative, all these things, So relatively, they are young patients, low stage, high tumor grade, scattered tumor giant cells, high mutations are present, classified as high risk by alcoholism, exceptionally good prognosis, treatment de-escalation, no radiation for stage 1 2, omit chemo even if they are stage 1 and 2, other parameters. So look at the curve, almost all 100 people alive at 5 years. So pole mutation is best to have, but unfortunately it is present in 10%. Then MMR, deficiency, 25 to 30% present. Majority are MLH1 promoter methylation, sporadic, higher grade, large number of TILs present, higher prevalence when there is a high LVSI, good response to RT. They do very well with RT, but they don't do well with chemo, so we don't give chemo. If you want to give, you give immuno. So including vaginal brachytherapy. Additional chemo does not improve prognosis if that patient has MMR. So remember this. Immune checkpoint inhibitor helps in pembrolizumab, usually we give. And look at the survival, 75% 5-year survival. Compared to T53, not bad. So if they are MMR deficient, what is the importance? RT, they are very sensitive, but they are not sensitive to chemo. Chemo doesn't have much role. Usually immune checkpoint inhibitors they give. P53, usually they behave like a serous endometrial cancer, ovarian rather than endometrial. Diagnosis is easy. It is identified on a IHC. So in 1-2 days you get reports. It is easily reproducible. Significant improvement in survival with chemo. They are all T53 mutated with any myometrial invasion. Not that to be more than 40%. So if somebody says there is a myometrial invasion less than 15%, some immediately to tell them there is an indication to do T53. Any myometrial invasion, irrespective of TNM, irrespective of node positive, negative, irrespective of the size, if they are T53 positive, they all need chemotherapy, radiotherapy, because they are very bad prognosis. But their survival improves by adding chemo to them. Okay, so without further treatment, look at this, survival is less than 30-40%. With adjuvant chemo radiation, their survival from 45% go as high as 65 to 70%. Okay, so also you look at HER2 pathway. If they are positive, you can give anti-HER2 therapy to do. Now there is another group which is NSMP where none of them are positive. You don't identify any mutation.
Sir, you are not audible, sir. Dr. Somashekhar, sir.
My presentation went up?
Yes, sir. So your voice is also...
Now okay? Voice better?
Yes, sir. Now is better, sir.
Okay, I think maybe I'm actually in Mauritius, unfortunately. So internet here in this beach area is very on and off. Okay, now it is seen?
Yes, sir.
Yeah, okay. So there usually, fertility preserving option even in cervix is possible. We know that now we have a radical trachelectomy, both either robotic through the abdomen or transvaginal. So read about this. Maybe I'll take one class on role of fertility preserving surgeries in gynecological malignancy. So there is a fertility preserving option available for early cervical cancer, for early ovarian cancer, and also for endometrial. Okay. So NSMP usually are amenable for conservative treatment. Remember this. Okay. They require further prognostic subgrouping using L1 CAM or beta. So their survival is also good. See, like 75% 5 year, but not so good as pole mutated. Better to have pole mutated. So these 4 molecular subtypes of this endometrial cancer, like ovarian cancer histology, they're essential and they're non-overlapping. In order of the frequency, MMR deficiency plus P53 first, then pole plus T53, MMRD pole positive, MMRD and pole plus T53. In this order, it's common. Okay. About 3% of the cases appear to fall in multiple group. Not all pole mutations are pathogenic. Pole A and T53 and MMR defect. Then you have to just remember, suppose there are multiple mutation. Pole takes the precedence. Pole takes the precedence. If pole is present, then you go by that. Okay. So now, is it all just theory or really patient? It's difficult to believe, somebody has more than 50% mammogram invasion, higher grade, everything, and you say, oh, no chemo, no RT required, and you say, are you crazy? Is it really true? So they applied this in PROTECT 3 trial. Okay, so look back this, it is adapted from this. So they found that when you do pole mutation, and if they are there, or if you apply, so MMR deficiency or deficiency, it exactly matched from this cohort of the groups. So we could classify into pole mutation, MMR deficiency, MMR proficiency, then you subclassify into T53 wild type or mutated, or NSMP or NOS, that is molecular typing not done, or inconclusive, or they are all negative. So we classify into all these things. So this is the first is to do pole mutation. If pole mutation present, that takes occurrence. If pole is wild type, then MMR. Then you subsequently define MMR into deficient proficient. If it is proficient, T53 mutations. Okay. So either way, we do all now in all the patients. So 4 molecular subtypes. So of endometrial cancer, clinical settings based on the age, reflection of disease, and genetic risk factor, different precursor, different prognosis now. And now you remember, you don't have to worry, oh, this is muscle invasive, non-invasive. You can just do a genomic NGS. And then you classify and know the prognosis, and you can predict whether this patient responds to RT, resistant to RT, chemo required, not required, no treatment required. Okay. So this is what is the implication. So by the current classification, we found that if you are not used this genomic, what I told, 6 out of 7 patients receive unnecessary RT. You know what is the main problem in endometrial cancer? We understage them. People do just a laparoscopic hysterectomy and come out. One problem. Or you understage the high risk and you overstage the low risk. Unnecessary pelvic lymphadenectomy in low risk endometrial cancer, where you don't have to do that, is a issue. What is understaging? When para-aortic lymphadenectomy is required, you don't do it. So under treatment of high risk by not doing para-aortic and not identifying proper stage and avoiding chemo, and then over treatment of low risk, stage 1A and 1B, by unnecessary pelvic lymphadenectomy and adding radiation. So this is the issue. Over treatment of low risk, under treatment of high risk. Over treatment with pelvic lymphadenectomy and RT in low risk when it is not required. Not doing para-aortic and adding chemo in high risk is low. So this is the problem. So if you didn't have this genomic classification in endometrial CA, 6 out of 7 patients receive unwanted RT without any benefit. Remember, today in rectal cancer and in endometrial cancer, radiation doesn't give overall survival. It just has a better local control, DFS, but no OS. If you think by giving radiation in rectal cancer, TNT protocol, and then in endometrial you're going to add overall survival, no. It just gives a good locoregional control. Chemo is the one which gives survival, and radiation just gives locoregional control. It doesn't add overall survival. It's very important to know. But however, there are some part treatment in the solid tumor of the solid tumor malignancy. Even though you don't get overall survival, locoregional control is important because they add importance to quality of life. Head and neck cancer. You tell a patient, oh, okay, I do this treatment. You still live 12 months. If I don't do it till 12 months, but it recurs. In head and neck, a recurrent disease can cause pain, bleeding, smell, not able to eat, presentable, cosmesis, intractable pain, nutrition deficiencies. Similarly, a pelvic tumor, bladder, prostate, rectum, cervix, you may not give overall survival, but if there is a local recurrence in that group, they suffer a lot. Fistulas, vesicovaginal fistula, rectal fistula, discharge per vagina, back pain, urinary difficulty, smell, and pain, so quality. So there are some places where even though you may not get overall survival, to get a better locoregional control, you may have to do, because that improves the quality of life and gives a good quality of life as long as they are alive, even though OS may not come. So now if you don't use this genomic profiling, 6 out of 7 over RT you give when it is not required. Today we know that if all the lymph nodes are negative, there is no role of adjuvant RT. You can just replace with vaginal brachytherapy. But if they are pole mutated, you don't have to do either of them. Second, 7% of endometrial cancer recur even in early because you miss P53 mutation and then you don't give chemo, or their or their MMR deficient and their chemo will not act. Checkpoint inhibitor required, you give chemo, so they recur. So 20% of true cancers who are platinum based treated. So which means over treatment and unnecessary treatment is based on the clinico-pathological. So morphology alone does not distinguish between these category. That is why pole, MMR, PT53 requires. If we apply our knowledge to this care, that we should not harm a patient if we can't help them, then pole, MMR must be incorporated in routine diagnosis. Pathologist must facilitate this. Okay. So now the algorithm. What we see, what happens is, if, because we know NGS is costly, 15,000, sometimes 20,000. IHC, most institutions have cheap. So even though the current recommendation is to do pole mutation, then they're pole positive, they supersede. Pole supersedes all of them. Then pole is wild type. Then you do MMR. Then you divide into proficient or deficient. If it is deficient, we know this fall into second category. Chemo doesn't act, sensitive to radiation, checkpoint inhibitor acts. Look for Leach syndrome. MMR proficient, T53 mutation, wild type. If it is wild type, then NSMP. If it is there, this is the algorithm. But see that it starts with pole, which is NGS. But most institutions, what they do is, they first do IHC, T53 very easy. Then they do MMR, MSI. And if one of them, if T53 is mutated, then you do pole because you can supersede, or if it is there. So to save money, we do IHC panel. If all of them are negative, then we do pole to look at it. Okay, that's what these people do. Okay. So now you can look back genomic classification: pole, ultra mutated, MSI, hyper mutated, copy number MSS, or high serous, like that is T53. So 35%, 5%, 1%, and more than 90%. Prognosis excellent, intermediate, poor. So now this was applied in real world scenario, and you can see they exactly showed the same. Look at pole, 100% alive, lifelong. So no chemo, no radiation required. Followed by MMR deficient. Then followed by T53 wild type. Followed by NSMP unclassified. Followed by T53 present mutated. So this is how you can classify, and look how survival drops down as low as 40 to 50%. Now when they looked the PORTEC 3 classification and applied 410 cases, they could actually replicate exactly the same what was shown. So endometrial cancer, PIGO grade 3, earlier thought to be stage 1B1 because they were more than 50%, and stage 2 and 3 and 1-3, all of them are applied, and 5 years survival, how it was shown very, very well, totally changed. Pole 98%. T53 mutated 48%, MMR deficient 72%, NSMP 74%. So this showed that there were 4 distinct categories which we can use, and this is how now from 2014 ESMO, ESGO, ESTRO was based on what? LVSI, FIGO grade 1, 2, 3, less than 50%, more than 50%, cervical stromal invasion, node positive, TNM, they classified as low, intermediate, high, advanced disease, metastatic. Look at here. Now molecular classification came. Now ESGO, ESTRO, ESP classification changed now into stage 1, 2, pole mutated, no residual disease, no further. Then intermediate is stage 1. So you can take a screenshot, read about it. Now this is already incorporated since 2022, and further refining has happened now over some time. So you can see that now molecular classification changed the whole treatment in endometrial cancer based on what you do completely. See this, all these things has been interrupted. So what is the impact? Post 2020, new guideline came which included molecular classification and led to the changes in this stratification. Okay, so all POLA mutated stage 2 are low risk and they don't need chemotherapy, radiotherapy. All POL wild type with myometrial invasion considered as high risk and they need treatment. High grade NSMP or MMR deficient. Okay, then you look whether there is TP53 or not, they classified as intermediate. Stage 1B high risk with LVSI and stage 2 are high intermediate, and if stage 3 or 4 pole mutation tumor, no risk classification currently. Okay, so endometrial cancer defined. So surgery, molecular classification, 1, 2, 3, 4 varieties. Then if they're pole A mutated, any myometrial invasion, even if they're stage 1A, they need both chemotherapy, radiotherapy, then look whether PARP inhibitor required. If they are MMR deficient, they don't respond to chemo, we don't give chemo. Low risk, early stage RT. If it is higher risk, you had immune checkpoint inhibitor, PDL1. If it is NSMP, then if you look at the low risk or high risk, and then they're classified, most of them take radiation, no chemo. Pole A mutated, all stage, no adjuvant. Okay, because pole present, no treatment. So this is based on a rainbow umbrella program coordinated by Transportec Consortium and allotted the patient. So this is the current guideline for the management of the patient. So you can see that again, low, intermediate, high risk, how it is integrated, and TP53 mutation with any myometrial invasion all fall into high risk. So they need chemotherapy, radiotherapy. Then at year 2022, Cosby et al. Published in Lancet further evaluation of this. Okay, so it is called as PROMISE trial and then PROMISE 2 trial. So they went one step ahead and they did DNA extraction. Then they found next generation sequencing of Poland T53 replacing the IHC based T53 and MSI assay instead of MMR. We all know that if we can do MSI assay, even though they both reflect MMR, MSI assay by IHC is very good than MMR assay, and then T53 by IHC is better than NGS is better than IHC, but the cost is high. So Cosby looked at all these things on this, and then they tested like this. Okay, so now how do we test? You do a biopsy, MMR, T53, ER, and HER2 all do. Then you look, if they fall into this group, POLA is supposed to be done. If it is mutated, then everything is superseded after surgery. Then group 2. When it is group 2, very low risk, you may omit POLA if all other comes negative. Then if it is group 3, POLA NGS testing is compulsory. Group 4, POLA NGS testing is recommended if only you need it. So this is a BAGP and BGCS guideline published in April 2022. Please Google and read this. Okay. So now I'll analyze in summary. Pole mutation is excellent. It doesn't matter you are in what aggressiveness of stage 1, 2. You don't give chemo, no radiation, no treatment required. POTEC 4A gave enough evidence that use of any adjuvant treatment in intermediate high risk is based on this. POLA testing should be carried out in all non-low risk patients. If found, it will obviate the need for any adjuvant treatment, and you don't have to do any adjuvant treatment in this group of patients. Okay. So now this is how at least when you start, if you can't do NGS, POLA, at least you must do MMR and T53. So now this is a guideline from the ESMO, that which is also adapted by ESGO. So endometrial cancer subtype, 2 pole, pathological, they become mole mutation, they don't need any treatment. Pole wild type, then do DMMR, and then if it is proficient or deficient, then you add T53 and then you classify into 4 varieties. So in concise, ready to use guideline I have put here. Stage 1, no further treatment. Astro guideline 1A, 1-3. But if any muscle invasion, do P53, then needs chemo radiation. So brachytherapy alone, no EBRT, no chemo. And you add external beam radiation if there is any muscle invasion, 1A with T53 along with chemo. And if they're POLA, then you don't have to do anything. Stage 2 observation, if pole mutation for all grades in histopathology, external radiation is added because I told you MMR deficiency, sensitive to radiation, not to chemo. T53 external radiation, stage 3, stage 4 all needs chemo radiation because they are advanced. Okay, I hope these two are good. In conclusion, now the decision for adjuvant treatment is based not just on surgical pathological staging but also on a genomic molecular classification. MMR TP53 IHC can be adopted very easily even in a low energy resource content. Whole needs Sanger NGS. So when it is indicated, please do it. Appropriate radiotherapy is the mainstay of treatment in intermediate and high risk. Chemotherapy along with radiation in T53 high risk. So don't over treat low risk, don't under treat high risk. Thank you very much. It's a very complex topic, but I just wanted all students to understand, what is this, otherwise you will never understand this. Now it's very, very clear, you understood this. Pole is done by NGS. If it is mutated, chemo radiation not required, 100%, almost close to 5 year survival. If there is MMR deficiency, chemo has no role, they're sensitive to radiation, immune checkpoint inhibitor you need to do. Okay. And if TP53 is mutated, any muscle invasion is present, myometrial. Initially stage 1A, no further treatment was required, node negative, less than 50%. But now, even if there is some muscle myometrial invasion, T53 needs to be analyzed because if it is positive, all of them needs chemo radiation, survival is 45%. Okay. So what I will do is let me check some questions if we can answer. Okay, so Avneet Kaur has asked, will you extend the surgery of lymphadenectomy depending on the molecular subtype? If so, should be or no? Today, if you know they are all mutated, you don't have to do lymphadenectomy. That is the only system where it changes. Remember this. Otherwise, now we don't do systematic pelvic. Now, what is gold standard in endometrial cancer? Pelvic paraiotic assessment by SLNB is the standard of care. No role of pelvic and paraiotic lymphadenectomy without doing SM, but you should have ICG firefly fluorescence as per the 5-star. So this is the recommendation. Always look for paraiotic node because they are most important. 4% could be isolated. Now I will look at this way. If for example, they are pole mutated, ultra mutated, actually type 1 THBSO will cure them. No, they would not need lymphadenectomy, they would not need chemo radiation. But based on the other things, surgery doesn't change. It's only the other. So subtype, if you can do before, okay. But the problem is you just have a small DNC specimen. As I told you, if you have a good tissue and patient is affordable, good to do that. Then you can know that you don't have to do unwanted lymphadenectomy. Later you don't have to do. But having said that, most of the time the right tissue is available after hysterectomy. Next question from Jansi. So if P53 is mutated, any indication that PL need to be done? Okay, now there is another point. P53 is so bad, even though there is no level 1 evidence, people feel no need to do lymphadenectomy because all of them needs chemotherapy, radiotherapy. To type 1 extrafacial THBSO, T53 mutated, they all need external beam radiation and chemo. Why do lymphadenectomy? It's an irony. If you know they are pole mutated, maybe they don't need lymphadenectomy because they are very good. If they are T53 mutated, they are so bad, lymphadenectomy doesn't change the survival. All of them need chemo radiation. So we have not yet reached that level, but it's right. If you can do before surgery, it's very good. But the way endometrial CA gets operated in India, postmenopausal bleeding, endometrial thickening, all of them have a laparoscopic hysterectomy simple by gynecologist. Oh, there is a cancer. Then they come to a cancer center. Then we get the slides, we get the blog, then we see whether there were more than 50% myometrial invasion. We have to go back for lymph node staging. There were less than 50% FIGO grade 1, grade 2 genomic analysis. So we work opposite in India. They just knock off the uterus and they come to us, unfortunately. But this point, what Jansi told, and Avneet, you are right. That's true. I didn't want to confuse and give you wrong, but you are right. Surya Prasad is asking, so we do only pelvic SLNB. Please do paraiotic also because, if you can have 4% paraiotic could be positive. 4%. But if you don't see remember, when you do ICG, all the time paraiotic is not the sentinel node. Roughly 40 to 50% of the time, paraiotic area shows a sentinel node. Just because sentinel node is shown doesn't mean they are positive. Only 4% positive. If you don't see a firefly, don't do. But a proper sentinel node would be not looking at the node, seeing the lymphatic where they stop taking the first acellular node, right and left. If you don't see, then that side you have to do systematic lymphadenectomy. Then let me see in the other place. Okay. Q&A, some questions are there. I think. Will the extent of the good? I think I answered everything now. Avneet Kaur. Fantastic. So I wanted to introduce you to this topic. Unfortunately, I came for some professional work in Mauritius, and it's a very odd time, early morning for us, 5 a.m., 6 a.m. Internet was not good. But I didn't want you to miss this class. It's very important. Please read about what I told. So this is what I normally recommend. Ideal, if you can do NGS based genomic profiling before you operate and know whether it is T53 mutated or POR mutated, lot of job is done. You can tailor make many things. If you can't, post surgery, if somebody has done a simple hysterectomy, not analyze the staging, they have not taken the washing, they have not done the lymphadenectomy, you first get the blocks, do a genomic analysis. If they're POR mutated, you don't have to go back for restaging and you don't have to give chemo radiation. If they're T53 mutated, again I don't go back for restaging because they're bad, they all need chemo radiation. Problem comes if they are NSMT type or if they're MMR deficiency, then always have an MDT tumor board. After you do all the surgeries, please do genomic analysis, because if somebody is stage 1B1, still they may escape chemo radiation or any treatment if they are polymutated. And if there is any myometrial invasion, because initially we thought stage 1A. What is 1A? Less than 3 centimeter tumor, less than 50% myometrial invasion, FIGO grade 1, grade 2. They don't need any adjuvant treatment, but now no. Any myometrial invasion, T53 assessment you have to do. If T53 is mutated, then you need to actually give chemo radiation, both even in stage 1A presumed. That's why you need to do that. Good, and that concludes my talk, and over to you, Arunji.
Thank you, attendees, and all the faculty members for joining the session. Thank you, sir. Thank you so much.
Thank you very much. Bye-bye.